Thank you, Dr. Ramaiah and the panel for inviting me. My topic is on non-bandaging therapy for the venous ulcer. Is it feasible? This is my disclosure. And now the agenda is to see what is the current management and review the challenges with the existing compression bandage and the novel therapy and the conclusion. We all know the management of the venous ulcer as the clinical criteria or the guidelines set by the American Venous Forum is compression. We recommend the compression over the no compression therapy. And even after the ulcer is healed, we need the compression for the prevention of the ulcer. Third thing is multi-component compression is better than the single component compression. And the fourth is when the patient has got an ABI of less than 5, compression is not advised in this mixed arterial disease. So the problems with the compression is multifold. I'm going to mainly talk about very important thing, which is inconsistent pressure. As we all know that even very well trained person, when they're asked to put compression, they don't know the quantification of the compression. They think approximately it's 20 to 30, but nobody is able to quantify the amount of pressure they supplied. The 2 studies have been done. In the first one, they showed multi-layer bandaging by physiotherapists who have been doing this for a long period of time. In that, 50% of the people did not apply the compression properly. And the second one, it shows only 20% of the people had graduated compression applied properly, and 17% had a reversal of the flow. That means more compression on the top and less on the bottom, and 63% had random compression. So, and the second problem is degradation of the pressure. As you know, when the effective compression happens, it reduces the limb volume, which means the reduction in the limb volume leaves the compression loose and it comes down. It makes 2 problems. One is the compression is not maintained anymore for the ulcers to heal. And second thing is, when the compression comes down, it becomes like a champagne leg, and the tourniquet effect of this slipped bandage can cause secondary leg ulcer. We all have seen, the studies have shown that 50% of the degradation happens within 24 hours of application. And you have seen in your practice, people come in like this. To put a bandage on these people, it is time consuming. First of all, it needs 2 people or somebody to lift the leg up. And typically, it's all done by the nurses or the PAs or the nursing assistants. And to do exact evaluation or exact amount of compression applied in these patients is not possible or it is not accurate. So the new advances in the wound care. So what is needed? We need an inelastic, accurate, constant, consistent, measurable, and easy to apply device. So we have this compression device called AeroWrap, which is inelastic air-filled leg wrap. It is Velcro on, so easy to put it in. And it's got a dial-in compression. That means we can change the compression from 20, 30, which is ideal for the mixed arterial to venous disease patients, to 40 to 50 in the lymphatic patients with a lot of swelling. And so obviously, this particular one, it is measurable, adjustable, and it maintains compression as long as it is on, and which is what we need for healing the wounds. And we did a couple of studies to show what we say is true. So this is, I can see 20, 30, 30, 40, 40, 50 was given to the legs, and it was maintained or it was duplicated in studies. And second is the stiffness index, which is which helps to see the venous return. The more stiff outside is better for the venous return or the lymphatic return, because when the muscle is pumping against the stiffness, it pushes the fluid upwards. And so AeroWrap had a stiffness which was better than what is in the market at the present time, 2.5 times than the Circade. So now the compression is addressed. Now the second one is the exudative management. As you know, these venous patients, they all have a lot of drainage. And when that happens, when there is soaked, in the present system, the fluid goes back into the leg and it causes maceration of the skin around the ulcer, and that causes non-healing or secondary infection. So we came up with this new dressing, which is preformed, so it fits the leg. It can be done by a single person, the patient themselves. It's peel off sticky, and it's made of like a diaper material, so it absorbs all the fluid and keeping the skin totally dry. You can leave it for 10 days, 15 days, 2 weeks, as long as it takes, because it does not leave any fluid behind. So it keeps it totally dry. And it can be easily changed as needed. And if the patient's the drainage is not too much, then you can just open and close and inspect the wound and change it. So as far as the wound is concerned, instead of putting the Uno boot all the way, we converted that into sheets. So just put it on right over the wound and put this system. So the other possibility is also remote monitoring. So there is a European country which is doing this. So you can monitor the pressure with the super sensors. So if the pressure comes down, they can warn the patients to increase the compression so that it is maintained all the time. So we did, with this, we did 30 wounds on 27 patients. They all had venous ulcers for a long period of time. Some had failed from standard bandaging, and they came to us. And they were seen weekly or bi-monthly, and this system was implemented. So the age was 64, morbidity, 29% had diabetes, and as you can see, 63% had lymphedema. That means they had swollen leg. And one patient had a biological dressing. And when the patient had saphenous vein incompetence, we addressed that with EVLT or the Varithena. And 74% of the patients healed within 14 weeks. The other 20% had the ulcers, like you said, 30 to 40 years, and they're still healing gradually. This is some of the samples of the patients which healed. This patient, actually, I'm talking about this patient was from New York. She went to Atlanta, and she was living about an hour and a half away from the closest clinic. In the beginning, she went to the clinic, and then they tried to put the bandages on, and for her, it was not feasible. So she stopped going to the bandage, and the ulcer got really worse. And then she called me up. She says, I want to come back and see you. I said, okay, come on over. We'll implement this dressing on you. So I gave her this dressing and taught her how to do this at home. She could put the Uno boot slips, and as you can see, the exucane on the bottom and the area wrap, and then she pumped it and kept it pumping every day. And with this, she couldn't even take a shower every 3 to 4 days, and she managed to do the dressing every day. Till it was healed. So this one, after 5 months, it completely healed. So this could be obviously done remotely without having the patient come to the clinic. And this patient, mind you, did not have any medical help at all. She did not want any visiting nurses coming to the home, or she did not go to any clinic. It was all done by the patient herself. So the case series shows that wound healing can be achieved without traditional multi-layer bandaging, because the one reason, it's a constant, consistent pressure and also improved exudate management. So this will be ideal for the venous patients who is homebound, so they can do it at home. And also when the patient comes to the clinic, they don't have to be bandaged. All that the doctors or the patient have to do is just look at it, reapply, and then they can go back, making the time much easier. And that means you can see more patients at the same period of time. Thank you so much.